Hey everyone, welcome back. For those of you who are interested in having a one-on-one conversation with me, where we can go over your Oscar data, your sleep study, or just your overall sleep disorder breathing profile, try to find some answers, I've left a link in the description box below, where I will also put Dr. Rama's contact information and website details. Good luck everyone, and I hope that you guys find some answers in this video. Okay, I think we're up and running. Oh, I like the background you chose too. Can you hear me okay?
Yeah, I just came to work and I kind of put it at an angle that is more relaxed.
Yeah, I like it. No, you did good.
Semi-professional, but I just came in my workout clothes, so
Oh yeah.
the weekend.
My first question, I always like to start with RDI and AHI because for some reason they're still super popular. If a patient has an RDI that's under 5 and an AHI that's under 5, is it fair to say that they don't have a problem? Or is that too surface level and a disservice to the patient to say such a thing?
Hmm. I think, Andrew, by you asking that question, you already know the answer. It's too surface of a analysis. Um, if the way I think about it is, the insurance company worlds, they primarily look at AHI. That's it. And so I think that's one of the reasons why everyone focuses on that. And they used to look at RDI to some degree, but obviously they want to, they don't want to cover as much. So they now just look at AHI. But the reality is, like, when we see a patient, I tell them their sleep study is just one piece of the entire evaluation. Number one, what does your sleep study look like? And I always scale it from a scale of 1 to 10. Your sleep study is a 2 or 3 out of 10. Does that make sense? Whatever, right? Or 1 out of 10 in this case, what you're describing. What does your rhinomanometry look like? Oh, well, your daytime breathing is, like, in terms of severity, 10 being the worst, it's like a 7 out of 10. Or what does your brain map look like? And I think, we'll talk about it later, but, like sleep apnea is like a traumatic brain injury. Every arousal and DSAT, it's like a mini concussion. It degrades the brain. And, oh, that your brain map's like a 6 out of 10. What are your symptoms like? And there's not always a even correlation between severity of sleep disordered breathing and symptoms. But if are your symptoms a 9 out of 10? We don't know, right? And then what's your exam like? Even though the study is a 1 out of 10, if you're retrognathic, your nasal valves collapse, the root for your mouth is high and arched, you have a crossbite. Well, obviously, that's like a 9 out of 10. Um, and and then we look at the strength of the muscles in the mouth, and like your left lip, right lip, anterior tongue, posterior tongue. We know in sleep disorder breathing, people are weak. They're like, you want to be like a lion or lioness, really strong in your mouth. Like, you want to be able to lick someone's skin off with your tongue, like, but or crush walnuts with the roof, your tongue on the roof of your mouth. But anyway, how strong is it? Is it like a 2 out of 10? And so anyway, the point is then, and then if you have the luxury of having a cone beam CT, you can see what the minimum pharyngeal airway space is. You can see if there's any transverse maxillary deficiency. You can see if there's any enlarged turbinates, or if the, palatine, lingual, or nasopharyngeal tonsils are enlarged, or if there's any bone spurs or, polyps in the maxilla, and if the frontal sinuses are occluded. Who knows? What I'm saying is, if you have the luxury of seeing inside, then you can grade that. So once I finished that, you realized how minuscule the AHI and RDI is. And I'm sorry for the long answer, but that's what it comes down to. And yeah.
So if a patient comes into you, let's say hypothetically, and their RDI is like 1 and their AHI is like whatever, half a 1 or 1, and in some of these tests, let's say they present poorly, at what point, like, how do you figure out if it is really sleep disordered breathing, or if maybe it's a little bit of sleep disordered breathing and something else, or something else completely? That's the thing I struggle to understand a little bit. It's like with
Um,
their airway might be small, but can you be sure just by looking at the CBCT scan, for example, with an RDI of, let's say, 1, that it is still sleep disordered breathing? Do we look
yeah.
at the pulse rate, or what are we gonna look at? to be like, no, it is probably still sleep disordered breathing?
Let's spend some time on this question because I think it's the same question as the first question. Just we're going to just look at it from every single angle, but just rolling back one point to the RDI, respiratory disturbance index. It's basically any reduction in flow with an arousal, right? But what you have to recognize is that what is an arousal and how do you measure an arousal? And obviously we're talking about cortical arousals, but where are you placing the sensors? Sometimes the arousal is evident in the frontal lobe. Sometimes the arousal is evident in the central leads. Sometimes you don't see the arousals, but if you had subdural electrodes, meaning you pierce the skull and you put them underneath the dura, like they do in epilepsy monitoring to determine the location of a spike, that's ultra sensitive, and you may recognize the arousal. So the point I'm making is, depending on how the sleep study was done, how good the equipment is, where the sensors were placed, even if you did everything right, there could be an arousal, but you may not have detected it. So, so the point I'm making is that the RDI is incredibly inaccurate. In fact, and that's why in some sense, I actually prefer the WatchPat RDI based before the RDI of a lot of labs. And the reason why is the WatchPat is basing it on peripheral arterial constriction. So every time there is an arousal, typically there's a small sympathetic surge. Your blood pressure goes up, your heart rate goes up, your arterioles constrict. And sometimes that's more reliable than the sensors various labs put on your head. And even applying the sensors, how are you applying the sensors? Are you using wireless, dry electrodes, which are terrible? Are you using wet electrodes where the conduction is better, but still not as ideal? Are you using paste to put it on, which is better? Or using colloidant, which smells like awful, it takes like an hour and you really stick it on, but that gives you the best signals without digging into the brain. So I don't want to go into too much detail, but you're asking me, what if the RDI is 1? I'm like, big deal. Does that make sense? I really don't care.
Yeah. So I think you already understand the position that I'm in, where I obviously strongly doubt the AHI and the RDI to begin with. But I was even put back when I figured out that there are patients who really do have an RDI of 1, and they've gone through surgery and literally cured themselves from what were lifetime debilitating symptoms. I'll have a patient on soon to give a testimony to that end, but I was curious, how many of those patients do you think you get, um, who have very low RDIs but are, let's say, severely symptomatic with the SDB daytime symptoms and consequences?
I probably see that on a weekly basis, at least one person. So very common. And um, and yeah, it's pretty common. It's not uncommon. That's why I don't think the AHI and RDI are a great measure. I really think you need to look at it holistically. And but you're also correct that how do you know it's not something else? Well, that's the answer to that is that you take them through various treatment trials and you see if those treatment trials cause an improvement. And what could that improvement be? It could be improvement in reducing the average heart rate during the night, reducing the breath rate during the night. It could be increasing the heart rate variability during the night. It could be keeping your glucose levels more more stable during the night where you don't drop, cause hypoglycemia, and you wake up. Because even that is the chicken or the egg. Is the glucose dropping or is it dropping because you're having sleep disorder breathing and causing the fluctuations? So you look at a lot of different parameters, and that's why we have this sleep tracker now that we actually, for our patients, we put them under the bed, and I have a monitor, and I can actually see their results. It's similar to every other consumer biometric. The difference is I have a dashboard that I can remote in and quote see your Fitbit data, for instance, or your Apple data, but this is specifically geared towards the sleep tracker.
Interesting. So, another thing I always wonder, I like to hear from doctors is, I did a video on this not too long ago. It was 2019 data from the Lancet, and it was trying to predict essentially how much sleep disorder breathing there is. However, they used the AHI, and the number was around 1 billion. Now, I've say in my videos sometimes, and I admit it's complete speculation, but I wonder what you think with respect to if we were to truly capture, let's say, the cohort of people with sleep disorder breathing, not just people with an AHI above 5, but RDI above 5, and then even people who, let's say, have an RDI below 5 and AHI below 5, but present symptomatically. What do you think those numbers are around at this point?
Oh my gosh, if you ask me, I think I mean, it's all a spectrum, but it's essentially probably close to 100%. I mean, literally everyone has it. The thing is, like, look, we're all a little bit overweight. None of us have optimal body fat composition. None of us have perfectly squeaky clean carotid arteries or coronary arteries. So no one is perfect, right? And no one's breathing is perfect. But at some point, it's like, okay, when does it cause? Is it causing symptoms? I think that's when you're anxious, you're depressed, you're ADD-ish, you have brain fog, you're forgetful, you're grinding your teeth, you have impotence, who knows what, right? And I think the reality is that's probably, I still think it's close to like 75, 85%. I think there's just 10, 15% of people out there with really good structure, good airways that have basically no symptoms and you don't need to touch it. Everyone else, we should be optimizing. The reality is we live well until, like we always talk about lifespan. Oh, we live until we're 85. And by the time we're 85, we'll probably be 90. But where's the usable lifespan? Around 65, everyone goes down the tubes. That last 10, 20 years plus is usually illness, not health. And so it's optimizing these people, these airways and other things like your sugar levels and whatnot at an early stage and investing so you don't have a crappy 10, 20 or more years at the very end.
Right. Okay, so in that context then, if everyone has sleep disordered breathing and I just can't even, well, you know, we'll say that loosely, but like realistically, a very, very large number of people, I think it's fair to say at this point, are suffering from sleep disordered breathing. And I don't even want to imagine the downstream consequences with respect to health that that's probably causing. How do we get out of this? Like, no one's really presented an answer to this question. How are we going to have a future generations where hopefully this doesn't exist, or are we doomed, or what do things look like moving forward?
I mean, I think what you're alluding to is this genetic or environmental? I mean, that's what it sounds like, right? Are we just born with this in some ways? And like everything else, nothing is 100% genetic, nothing is 100% environmental. It's usually like a ratio. Um, in my opinion, I think I'd like to believe that and environmental plays the biggest part and genetics plays a smaller part. Yes, I think there's a certain group that can get Down syndrome, or maybe there's an obesity gene, or maybe there's a gene for something else that causes some type of cranial dystrophy, or something else that impacts the airway. But in general, I'd like to think that everyone has the opportunity to develop optimally, no matter what race you are, what gender you are. I think there's an opportunity that if you holistically, stay healthy, that you can ward off any significance. You probably still have a teeny bit, but nothing that you'd ever have. Like the hunters and gatherers weren't wearing CPAPs. They weren't, and the Eskimos aren't wearing CPAPs, up in the North Pole there, right? So, I mean, so I think I'd like to believe that if you go back and to these indigenous areas of the world, they're fine and they live good. They have broad mouths and good airways. And I'm sure if you test them, they got a little bit of sleep disorder breathing, but it's irrelevant. And there's almost some cultures don't even have a word for depression. I mean, so but I will say that also, like, this is just throwing it out there. The environment makes a difference. And, we always talk about like, we live indoors now, there's more pollutants, whatever, this, that, we eat processed foods, and that has an effect on our breathing too. But, there's even people who say that like C-sections, when you're born by C-sections, your dysfunctional breathing begins at that point. It's because you have to go through the canal, and have all the lungs squeezed and everything expelled from you by the time you're born. And if you're not, you're born with all this crud inside your body, and then you learn how to breathe improperly from moment one. So, were you born by C-section? That's not natural either. Just something to think about, process that it can
Yeah.
start very early.
Yeah, it seems like when we deviate from any of our old practices, something seems to go awry. Speaking of unnatural things, um, so why, that's one, let's say, contributing factor, but what are the biggest reasons that this even happened? Because my understanding is that, whatever, 500 years ago, this didn't exist. And I think there's also literature that shows certain populations in the world don't even have this, like you just sort of alluded to, with respect to, I think, the Eskimos. So what did we do wrong along the way? And can we stop doing those things and will it fix, or is there still some collateral damage that we'll have to fix it in a different way by doing more than just stopping whatever caused this?
I found like there's I mean, apart from all these random small things, the two main things are either tongue tie, right? So the most important bone in your body is the maxilla, and that's because you breathe through it. But the most important muscle in your body is the tongue, because it shapes the maxilla. And as it puts pressure on the roof of your mouth and it spreads it, and you grow the maxilla nice and wide. If you're tongue tied, it doesn't reach there. And then all the other muscles, the lateral pterygoids, medial pterygoids, masseters, buccinators, whatever, all those muscles have a small but over time effect, like restricting the maxilla and making it like that. But really, if I almost always ask patients, okay, they don't have a tongue tie. Do you have allergies? And almost 90% of the answers is yes, I had allergies, right? And I think that's it. And what you said is, can we get out of it? The reality is, back in the hunters and gatherers age, they would go to a certain area, pick the fruit, hunt the animals, and when it was devoid of food, they would leave and they go to the next area. And they slept outside, usually on the ground, underneath the moonlight, with a probably a little small thin blanket at most, and maybe who knows what they use for their neck, right? And that's it. And they certainly just ate what was natural. And I'm sure a lot of times even semi-raw food. And here, now we eat processed foods and we're living indoors and we have a lot of unnatural, I think we just have exposure to incredible allergens now, both internally and externally. And I think it's as simple as that.
Yeah, I always have long thought on that too. I studied biochemistry, and the number of new molecules, for example, that we have made that have no long-term data on it baffles me. And it's almost like there's so much noise to signal. It's almost sounds like it's almost like you just have to leave civilization because there's
Mhm.
so many chemicals that are essentially not being monitored in the way that they probably should, that are new, that could be causing some sort of physiological storm, maybe for
Mhm.
some small percentage of people, or maybe for a large percentage of people. But one thing I wanted to double click on was the tongue tie stuff. This has received a lot of flack over the years, but I've always been sort of trying to support the inquiry. Dr. Saru Sagi at the Breathe Institute, I think, is pretty heavily involved with this stuff, and he got criticized pretty heavily. What does this landscape look like now? What is the literature around tongue tie saying,
I
and how
mean,
many people have it?
I think regarding tongue tie, I guess it depends who you speak to, right? And Dr. Zaghi, he's a great doctor. I think, I think he's on the top of his field. But, I think someone who's a myofunctional therapist, someone who's like a Dr. Zaghi who focuses on tongue tie surgeries, will be able to detect all the subtle cases. And it's just like the sleep disorder breathing. Who has apnea with 4% DSATs versus hypopneas with 3% versus RERAs versus just snoring? Does that make sense? And so I think if you the literature doesn't suggest it's that high of a percentage. I don't have the exact number on hand. I apologize about that, but it's not it's not like 90% or anything like that. It's much, much lower. But, you know, I am more holistic. I think personally, I think it's a little bit overdone. You know, so for me, if I can't see the tongue tie in my office and it's not substantial, and that's one thing, right? And then I don't even bother with it. So if they tell me, oh, they got this posterior tongue tie distance, but doesn't look like it's a problem, I don't worry about it. The second thing is I always, like I said, we measure the strength and everything. And if it's low, you know, the tongue has this, you know, 60% of your face develops by age 4, 90% age by 12. So most of the development was at an early age. It still supports it, prevents it from collapsing, perhaps, you know, but it's minimal at that point. And so for me, if I try to normalize the strength with our little strength, you know, IROPI device, and once it's normal, what I tell the patients is if you can maintain that strength, then you're okay. But if for some reason you're unable to maintain that strength, then perhaps it's due to the tongue tie and you're not able to, you know, use the tongue in an effective manner, then maybe you should fix it. You know, so either A, I fix it if it's severe, B, I fix it if they can't maintain their tongue strength and there's a tongue tie and it's not as severe. And that's how I look at it. But I am not a tongue tie expert per se, you know, in the sense like a Dr. Zaghi. And I'm not certain that like they'll, you know, there's data showing that, oh, maybe it'll help sleep apnea if you treat it. I'm not convinced about that. So I think I go elsewhere because usually patients have so many other issues that, you know, fixing the tongue tie. Like I've seen plenty of patients with apnea post tongue tie release. I don't know, but they usually in general do say that they can move their tongue much more, they can use it much more. So I don't think many people have regretted their tongue tie releases. So the question is, you know, first, do no harm, but the second thing is that doing a benefit.
Right. Interesting. So the whole tongue tie thing, am I understanding correctly that it's basically like a range of motion thing? Like if it's tied, let's just say you don't have your full range of motion with your tongue, and one of the consequences of that is that you're not going to be able to sort of apply the pressure of the different thirds of your tongue up against the maxilla, and then it may not develop properly, and then you may not breathe properly. Am I going down the right path with what they're
That's exactly it. Yeah. I mean, like if you look at infants, their tongues are just sucked up right on the roof of their mouth. You know, it's just it's natural for that to happen. But if it's tied, you know, hopefully they catch it when they're early. But that's the like I said, the most important bone is the maxilla. The most important muscle is the tongue because it shapes the maxilla.
right? Okay.
Anything that impedes it, a tongue tie, a straw, a sippy cup, a thumb, finger, will change that process.
So speaking of the maxilla, so I just got maxillary expansion. I was listening to your Jaw Hacks podcast, and you were talking about the rhinomanometry and how that allows us sort of to objectively measure the airflow through the nose, which for anyone who's just starting out here, maxillary expansion is supposed to improve your nasal patency and breathing. And it made me think, like, I think you even said this, so I'm not going to take any credit, but I think you said if someone's expanding, you know, they should be testing their rhinomanometry so that they can sort of identify maybe where they should stop. Because if, you know, if they've expanded X amount and they're not seeing any, let's say, further improvements in their rhinomanometry, then there's kind of no point, provided the relationship between the maxilla and the mandible has been resolved. But sorry, you're a smart guy, so I'll put that on the side burner for 1 second. Do you want to just tell us first what rhinomanometry is, and then we can come to that question, and I'll repeat it sort of in the abridged version. But what is this rhinomanometry thing?
So what rhinomanometry is it's a fairly simple test. You put a face mask on and you breathe 4 breaths with you put a foam plug into one nostril and you close your mouth and then you breathe through this mask. for 4 breaths. And then you take the foam out, stick it into the other nostril that was, and you put the thing on and you breathe for 4 breaths. And what it's basically measuring is 2 things, your nasal resistance and your nasal flow. And we know what normal is. And in essence, I'm just going to show you some simple tracings, right? And then I'll show you some numbers later. I didn't put the numbers on the website. Like for instance, this is what relatively normal resistance looks like. So this is the right nose inhale, right nose exhale. So this line refers to your right nose, and then this line refers to your left nose, inhale and exhale. And you can see where inhale is written here, exhale, inhale, exhale. So together they make an X. The walkaway point is the more vertical that X is, near the y-axis, that means your breathing is good. Low nasal resistance, high nasal flow. The more horizontal it is, that means the worse you're breathing. High nasal resistance, low flow. Specifically, you want to see where it crosses the line. And light green is normal, okay? But even in the light green, this would be a small frame human. This would be a medium frame human. This would be a large frame human. So even this could be abnormal if you're a larger person, even though it's in the light green. Dark green is a little abnormal. Now I'm just using these, I'm making up these terms, but just something you can walk away with. Orange is dangerous and red is critical, okay? And so this person could be normal if they're, let's say, just a...
Are you talking about where the X ends at the top?
Yes, where the X crosses the line here, where it would cross the line.
Sorry, what are the units there too? So like where the X crosses in the top right of the X, what are the units?
That's in cubic. So the y-axis is cubic centimeters per second. Okay.
So flow.
It's flow, yeah. And the x-axis is pressure. Don't quote me on this. I believe it's pascals, centimeters cubed per second. Whatever. I don't know. I got, I just say pressure. I don't, no one really asks me that question usually, right? But it's fine. It's something, right? It's some kind of pressure. And then, so like, for instance, in this nose, like if you look at this person, you can tell automatically the left nose is worse than the right nose, right? And specifically, you can see that it's crossing in the orange section, right? And then if you look at this person, this is the right nose is worse than the left nose, right? And then what's that?
What is each line? Why are there multiple lines?
Because that's each breath.
Okay, that's what I thought.
And so when you see a dispersion, like a difference in the lines, that means that there's effort. So like it wasn't smooth. Does that make sense? Like you're drawing a circle, but there's like, a little bit of error, between breath to breath. So usually the more dispersion there is, now there's no like tool for measuring dispersion in rhinomanometry, but when I see it, I figure there's more effort. Does that make sense? There's more volatility, and that's not a good thing. Like this person's breathing is worse. You see that it's the right nose is in the abnormal, is in the dangerous zone, and the left nose is in the abnormal. But look at the spread. I mean, it's not ideal at all. Anyway, and then I'm going to just take it to one more level and show you, like for instance, this is what a nice one looks like. You see this? I'm not sure if it's big enough. Oh, maybe I don't know how to make it a whole screen, but can you see the screen or no?
Yeah, I can see it.
Okay, so this is nice because it crosses in the high green, but I didn't show. I'm just adding on the details so people can absorb it. So, but specifically here, do you see this? Inspire left nose, inspire, expire left nose, inspire right nose, expire right nose, right?
Yeah.
That's actually, I don't think I have it all in there, but that's in cubic centimeters per second. That's actually telling you the actual flow number. And you notice this person is 850 cubic centimeters per second, inspiration through the left nose. Expiration through the left nose is 709, okay? And the right nose is 830, and the inspiration in the right nose is 830, expiration in the right nose is 692. Anyway, blah, 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 blah. What's normal is 500 to 800 cubic centimeters per second. So whether you inhale through your left or right nostril, each one should be 5 to 800. Each one should be 5 to 800 out. Now, like I said, it depends on your size. If you're a small frame person versus a large frame, that can vary. Also here, this is the resistance. Do you see this 0.176? This is that Pascal per centimeter cube per second or whatever. I know, whatever. But it's 0.17, 0.21, 0.18, 0.21, whatever. Normal is about 0.2 to 0.3, roughly, okay? So if it's higher than that, that's too much resistance. And so I'm gonna just banish that and show you, like, this is a person who had ease, okay? And unfortunately, we had just got it, and when they ran it, they didn't put the lines in to get the numbers here. But anyway, I got the post. But you can see that they weren't quite done with these. It was still in there, right? But they were towards the tail end. But you can see that when they first came to us, they were, crossing in the green. It wasn't miraculous, but it did improve the flow a little bit, right? So it wasn't a miraculous. And so people think that, oh, I'm going to get my expansion and it's going to be the end on cure all, right? And that's it, right? And so this person's at the tail end now they're in large turbinates, right? So I'm going to back up and say things. What are the 5 reasons? What are the 5 reasons someone's rhinomanometry sucks, right? Like your flow is just bad. Number 1, you got tons of inflammation, just tons. Your turbinates are inflamed, whatever, right? Your tonsils are large, palatine, nasopharyngeal, lingual tonsils, whatever, inflammation, everything is just blocked. The second thing is a structural abnormality, like you have a deviated septum, a bone spur, a polyp, or whatever, right? The third thing is that your entire maxilla is small, which is what all these talks are on and whatnot, right? Nasal maxillary expansion, whatever, right? The fourth one is that you're so recessed, your jaw is so incredibly recessed, your pharyngeal space is so tight that air can't go through your nose, right?
Is that the mandible, the maxilla, or both?
It could be both. I mean, we often think of usually whenever the mandible is recessed, almost always the maxilla is, just it may not be apparent. And then the final thing is you're weak. Like you literally have weak respiratory muscles and you're like an ALS patient. They're wide open, airways no problem, but they just have no effort. And that's something we can't measure. So it's a myth to think that just, so this person improved, but let's look at it. So you can see that the left nose looks better, right? And the right nose looks okay, but let's look at the numbers. Okay, well, the flow is still in the left nose, inspire and expire 300. Well, remember I said normal is 5 to 800. Now this is a smaller framed human, but it's still about 40% below where I want it to be. And then in the right nose, it's about 2. Now they feel they're breathing much better. So I'll say subjectively, they said that their average heart rate is lower, heart rate variability is higher at night. They can exercise with their mouth closed. They're dreaming. They feel good. But when they get in the office, I tell them, well, you're still about 40% below normal, and you're still about 50% below normal in your right nose. So your total inhale is about 550 cubic centimeters per second. Your total exhale is about 530 cubic centimeters per second. That should be 1,000. That should be 1,000. So the good news, I said, is you still have a lot more upside. But I don't know if widening you like the Joker is the answer. Does that make sense? I mean,
Yeah. Oh man, this is so interesting. I have so many questions, but I'll try to distill down to the best ones. So if this patient went and got, let's say, an MMA, you would expect these numbers to improve probably drastically, right? Or is that a bit of a stretch to say something like that?
It depends it depends where the resistance is coming from.
Right.
Honestly, like a lot of people, almost everyone has allergies. Almost everyone's turbinates are inflamed. So we
How
grade
do you deal with that? How do patients fix that? That's not, and that's, we don't just slap a maxillary expansion on that, right? There's a different way to
No,
deal with it.
I think number one, well, we grade the turbinates with the cone beam CT, grade 1, 2, 3, 4, grade 1, 0 to 25%, grade 2, 25 to 50% of the space it takes up. You know, a grade 3 is 50 to 75%, grade 4 is 75 to 100%. And well, you know, if it's a grade 1 or 2, I just send people home. Hey, try Astapro at night before you go to bed. Try Flonase in the morning. Try some saline spray in the shower, and do that for 6 weeks. Come 6 to 8 weeks. Come back and let's repeat the scan and see if it's shrunk or not. If it's grade 3 or 4, I send them straight to the allergist. I'd say I don't want to deal with it. And if there's some polyps and rhinosinusitis in the various sinuses, right? And then, you know, they can do their formal testing. They can put them on immunotherapy. They can put them on budesonide rinses. The more aggressive stuff that I prefer not. I don't like people on long-term steroids because even that can cause osteopenia and all these other issues, right? Long-term. But if that doesn't work, I'll say, come back after you're done. We'll scan you again. And if you're small, great. If you're not, I'll send you to the surgeon. Now, I'll tell them there's a couple options. Number one, you can do radio frequency. A lot of people don't like it because they grow back. What that is, you know what turbinate is? It's basically 3 bones. I can show you in the diagram here. Basically, you got these inferior turbinate, middle turbinate, and superior. It's just 3 bones, and then there's flesh on it, and that flesh can swell, and it's that. So one thing is that they could stick a needle underneath the flesh, but over the bone, and then just burn, and then it shrinks everything down. And they can do that in the office, not as well, because if they can't numb it all the way back, they can't do as much as they could in the OR. But it can grow back if the cause of the inflammation is still there, like you're allergic to something and you're still, seeing it, you're exposed to it. The second way is it's called a submucosal resection, where they go underneath and they actually break the bone down, and they can more permanently shrink it down. But that's more violent. You're tearing up blood vessels and everything else, right? But it is more of a longer lasting thing, right? Remember, the turbinates have a function. They're there to humidify the air, dehumidify the air, cleanse the air, create a laminar flow so your lungs receive it in a nice way. Anyway, there's a purpose to them, and you don't want to get empty nose syndrome by removing them too much either. So you always want to be careful. And I've got some patients that just do radio frequency once a year. I mean, it's not ideal, but they do it, right? And but anyway, there's no one way. Those are very difficult to manage, the turbinates.
Now, a question that still seems to be unanswered, and I feel like rhinomanometry could perhaps play a part in adding some color, is that it still seems to be undecided whether the 3-dimensional maxillary expansion or other standard maxillary expansion, whether one's superior to the other. Dr. Benjamin Walling told me there's not enough data. I just interviewed Dr. Coppelson, who does do the 3D and does disconnect the pterygoid maxillary junction. And even he admits there's anecdotal data that's starting to suggest, and we know, of course, Dr. Casey Lee, does the 3D and removes at the back as well. Is this something you've seen at all in your rhinomanometry data, where, for example, either a Coppelson expansion or a Lee expansion, those ones are showing in aggregate better improvements in flow versus other maxillary expansions? Or would you say the same thing, that the data is still unclear?
I have seen improvement in rhinomanometry on every single expansion, whether it's an MSE, double MSE, EASE, dome, whatever, right? I haven't seen any mines yet from Dr. Coppelson. I haven't seen any rhinomanometry, so I can't comment, but I'm sure it's no different here. I think for me, with an expansion, I've got, a couple of requests. Number one, I always tell the patients, be mindful of symmetry. Try to be symmetric. Try to get it symmetric. To me, that means, if you're not a teenager, like you're more of an adult. As a teenager, I think you can just do a simple MSE or MSE-like device, right? If you're an adult, I think it's important to do the pterygomaxillary sutures This way, you're more likely to get a symmetric split. But even as an adult, you can do a regular double MSc or something like that, or custom MSc with more screws or an FME. But I think it's important to just super monitor it like carefully so that you know it's even. And if it's not, you can just abort
How
and
do we do
stop.
that?
Huh?
How does the average patient monitor? Well, this is obviously a self-serving question, but how can I monitor to make sure I don't get asymmetry? What's the best things that I could do hypothetically? Let's say resources are endless. What do you do? Which is
Well,
the case,
if
but
you had, let's say you had no resources, you just take a look at yourself in the mirror. Are you developing a cant, in any way? Or is the split no longer midline? See exactly where the split is versus your nose, right? And just make sure it's split evenly. Um, and I think and then you just have to just almost take a picture of it so you can see it over time and make sure it's very even. I think if you had the luxury of a cone beam CT, you could just do repeat scans once every couple of weeks and try to, have someone who's knowledgeable look at it, and transpose it over each other and see that the split is. But I think that's a little overkill. I think essentially just look, when you can usually see the asymmetry, and you know, a millimeter is not a big deal, or two, even 1 or 2 millimeters, not a huge deal. So no one will notice that, and you can stop it. But once it gets to 3 or 4 millimeters or 5, oh, it looks off, and people will notice it, or they may notice, or at least you'll notice it. And so anyway, I think the simplest thing is just watch and to know to look for it. And a lot of people will come to me with expansions and they're asymmetric and they don't realize that, hey, that's not normal. Oh, the orthodontist just says they'll pull my teeth back. Yeah, but is it symmetric, right? Like they'll pull it back, but the orthodontist, they can move the teeth back and make it symmetric, but then are the jaws, if one is going this way and the other one is stable here, then it's not quite symmetric.
is it game over if you run into asymmetry, or what happens usually?
I think there's one thing aesthetically, if it doesn't bother you aesthetically. The second thing is that any type of asymmetry is going to cause asymmetry on your jaw joints, right? Like it's going to, over time, you may not notice it in year 1, year 5, but maybe in year 20, 30, you're just slightly degrading it. So if you're a kid, it's probably more relevant than maybe if you're in your 30s, 40s, or 50s, maybe, right? Because you don't use it as long, but that could be an issue. No one talks about that, but even MMA, it puts extra strain on the jaw joints. That's why if you have a lot of TMJ, they're very careful with those patients.
100 years ago in this interview with you and I asked a question along the lines of, do you feel like rhinomanometry can play an important role here in figuring out where these maxillary expansions should be stopping?
Mm. I think rhinomanometry is just one more tool. The reason why I'm saying that is if, like, you've probably have already mentioned this in your talks maybe, but a lot of times the turbinates, if they're inflamed, they just become more inflamed and just take up the extra space that the nasal maxillary expansion provided. And it's almost like they were restricted with the small maxilla, just like you are. And once they were free, they grew more. And so it's not this expansion. But I do think if I had my way, I do like to, at the level of the first molar, I like to measure the width of the nasal concha. And I like to see that has widened as much as possible. So if Dr. Coppelson, for instance, says, I widened you 8 millimeters. Well, how much did you get at the nasal concha? You were originally 33 millimeters and now you're 38. Oh, okay, that's pretty good. But what if you went from 33 to 34? Well, maybe that's not as good, right? So I know even in the MSCs, we like to measure the width there before and after.
It's my understanding that you went through maxillary expansion as well. Is that true?
Yeah, I was early. So I was one of these Andrews and Rons and whatnot years ago. And so the hottest one available at the time was Dome. And I know they still do it out there, but it is a disaster. Don't do the Dome. Absolutely not, right? And but anyway, they caused I think like a 12 millimeter diastema or something. But then my teeth got pulled back. Both front teeth are dead because they had to move the teeth so much. All the roots resorbed. The gums recessed a little bit. And then I had 4 millimeters of asymmetry. It's just not an ideal procedure. But you know, it's okay. It was what it was. And I'm just saying right now, all the people who feel pity for me, the people getting expansions 5, 10 years from now will feel pity for you because whatever
I've thought about this. You know, it's kind of messed up. Like patients are in this weird position where they benefit almost exponentially by waiting, you know?
Yeah, you're better off
Simultaneously,
waiting.
they're like, you know, their youth is being robbed of them. So they're in this position where everyone's just so plugged in, right? Trying to figure out what's in vogue next because things are moving so quickly and yeah. So
Yeah.
how bad was your sleep disorder breathing? And you did an MMA too, right?
Yeah, I did MMA too, which, you know, but which also had a lot of, you know, my right tongue is numb. It still feels like lightning when I touch across my lip. All my gums are numb. The genio was cut too high, and so the roots resorbed below my bottom front teeth. Um, and and they introduced more asymmetry with the MMA. I mean, you know, it was a disaster. But I did, like I said before, despite all that, despite that crazy, all the consequences, side effects, and I didn't even complain. I mean, you know, I just whatever, I just bear it. But I do feel better.
Well,
Would
how
I
bad
do it
was
like
it?
this again? I
Were
would
you
pick different surgeons. I would pick different expansion procedures, but it's okay, right?
so how bad was it? Were you like sidelined from life
Oh,
or was
I
it
was
just an irritant or what was it for you?
going back to your original. I was like you because I've always worked out. I've always been lean and whatnot. My AHI was like 0.91, but my RDI on my polysomnogram at Stanford was normal, less than 5. Everything was like less than 5. I was that patient.
Wow.
And then I was demoing a product for this huge organization. They're like, can you try this watch pat out? And this watch pat was like, this is 20 years ago when the first came from Israel. They came, I said, sure, I'll try this thing out, right? No one even heard of this thing. Came back, AHI 1, RDI 17. And I said, what the hell? This watch pad is picking up all these sympathetic, or I did it again, same thing. And I said, this watch pad is picking up what the Stanford polysomnogram didn't pick up for me, right? And why? And it's not their fault. I looked at the study myself. I didn't see the cortical arousals either. So that was the fascinating thing because I looked at my own study. I go, this is crazy. I'm normal. I guess. So then they kept thinking I had narcolepsy, and I go, I don't think I have narcolepsy because my airway's small, my chin was recessed, you know, everything's tight, you know. But anyway, the point I'm saying is, in this instance, yeah, there's like I was that person now that I think about it. You know, the person with the normal AHI RDI based upon a gold standard study. Yeah, I even did PEZ. I even did the PEZ, and the PEZ came back was normal too, surprisingly.
Wow,
But
you
you
know,
know, in 10% of people, the PEZ actually stents the airway open. So it could have been that the PEZ actually promoted, you know, like maybe that's why the PSG was negative. Does that make sense? I don't know. I can't understand it, but the watch pad nailed it. And then after the watch pad, I put myself on CPAP. I'm like, oh, I feel better.
wow, I mean, I know it's at the expense of your suffering, so I'll try not to smile too hard, but I mean, this story is almost too good. Did this play, you know, sometimes the worst thing that happens to you is the best thing that happens to you know?
Oh, I'm going to tell you all sorts of stories. Like I had chronic stomach aches, and the doctors put me on Tagamed. You know, Tagamed's like this antacid. And then I took Tagamed for so long as a kid that I got I mean, it's not bad, right? But you know, it's called gynecomastia, where your chest gets extra fat in that area, right? You know? So it's okay, I work out, but what's up? But my chest is a little bit bigger than it should be, but no one has ever noticed anything. But the point is, I got gynecomastia from taking lifelong, and then I would get chronic constipation and like stool difficulties and whatnot. Then my dad would take me to my dad's a doctor too. He'd take me to a GI doctor right in town, and then he'd close the door of the GI doctor. He would ask me, "Are you gay? Do you have gay sex?" I said, "No, this is real." Like, so I'm a kid, like I'm in like sixth grade, and the guy's asking me if I'm having gay sex or something. I mean, no, and so, and anyway, and then I would have the stomach aches would come back, and I've been scoped, and they tested me. There was nothing there. There's no ulcer or anything, right? They're testing me for like H. pylori and all this other stuff.
Wow.
And then I got ear infection so bad that they had to put tubes in my ear. That didn't work. They finally had to do it. Then the hole wouldn't heal. They did a tympanoplasty where they sealed over with the graft. I mean, I don't want to bore you, but these are looking back, everything was sleep disorder breathing. I was spastic, a little ADD-ish, and they wanted to put me on like, medicines for that, right? But I sublimated it well, for my studies. So yeah, I think it is. I look at all the doctors that missed it.
It is amazing. I mean, your whole story is like the gold standard.
Yeah,
Um,
and even as even only person that really caught it was Dr. Gimeno, Christian Gimeno. First time I stepped foot in the Stanford Fellowship, he said, "You need to fix this." I said, "What are you talking about? My study's normal." That he just had me say.
did
um,
this play a role in who you became? Were you going to be a different person and then you realized, hold on a
yeah.
second. It's too important that we got 10 minutes on the thing here and then we'll have to, it's too important that I go into this direction because of what I now know and what I've now been through. And then you became a sleep physician, or were you always destined to be a
Oh.
sleep physician?
I think subconsciously I gravitated towards sleep. Does that make sense? I didn't even recognize it until afterwards. But because of what I went through, and it took 28 or 9 or 30 years for the light to go on. And that's why, like I was even like these institutions, not Stanford, another institution, I would be treating patients like I would treat myself. I recognized it early. I could tell early on that, hey, this person's got it. I don't care what the studies show. They've got it, right? And but I would send referrals off. The surgeons would yell at me, "Why are you sending referrals for this kind of patient? They're normal. They're normal." So I'm getting pushback from the entire medical community, right? And that's why, as of 3 years ago, I just went private. Screw it. I can't deal with these people. I can't deal with the corporations and the institutionalized medicine. And so I went private. And now, finally, I'm free and I can treat the patients, give my advice, and I only send them to people who are like-minded that see the light also. And that's made the difference. So now it's seamless.
Yeah, I look back to, I actually wanted to be a doctor once upon a time too. And I sometimes, well, I still think it would be a very meaningful and, let's say, enjoyable job, but I feel like I was almost destined to not be stuck in the bureaucracy in some sense, and to help people outside of it. It feels like, I don't want to get too conspiratorial, but it almost feels like those in the ivory tower, they just don't want to hear this at all. And because top physicians basically around the world, but I mean, we can just isolate the conversation to Stanford, have been screaming about this for 40 years. And here we
Mhm.
are, and it's getting worse. And people are getting neglected, it seems like just as much or more, and dismissed and gaslit. And I help patients optimize their PAP settings, and I get people from all across the world, tons of countries. I hear the same story over and over and over and over. It's literally copy paste. No, it's in your head, right? Or let's check your blood levels, or it's just anything but sleep disordered breathing. They don't even want to talk about sleep disordered breathing. Oh, we put you on CPAP and your AHI is below 5. There's no way it's sleep disordered breathing, over and over and over again. And then there's people like you and Gimeno and Lee and just these centers of sleep excellence around the world who have been publishing droves of literature and screaming the whole time. And it's like we haven't even moved, it feels like. Do you
Yeah.
feel that?
I
Like,
think there is a greater awareness now, but it's still trivial. Like people like think what I do is special. And honestly, I don't think anyone does what I do, but it seems basic to me. And so like when I ordered my cone beam CT, the rep said, "You're the only sleep doctor I know that's ordered, at least in the Western, side of the US, right?" When I ordered the rhinomanometry, she says, "You're the only sleep doctor in North America who's ordered one. I have some guy in Europe that got one, right?" And then the hypocapnia equipment, the rep from Massimo called me and said, "Why do you want this?" You're not a hospital. What are you testing for? Like you're testing for hypocapnia, and so the brain map people, they have to create the equipment, like they had to create it for me because they're like, "What are you doing? Why are you measuring alpha?
oh
We don't
my,
even understand. What are you doing?" And so there's a lot of this. But to me, it's because I started with my own enlightenment 20 years ago, and it's developed into this. And I don't know, maybe it worked out for a reason, but everything I'm testing. And so when people like yourself and others see me, it makes a lot of sense, all the testing I'm doing. I'm just ahead of them. I'm already telling them things that they didn't even think they needed. Hey, you need rhinomanometry. And then even what's fascinating about the hypocapnia, we just got that equipment 3 days ago. So I tested 14 people. How there's this theory about buteyko breathing. Oh, you're over breathing. I've been doing CO2 for 20 plus years, and it's always hypercapnia we're looking for. Are you underventilating? Is your CO2 levels too high? I know we only got it. But fascinating, the people are saying people overbreathe. And so I thought it was the strangest thing. I said, well, everyone's rhino is awful. Their resistance is high, their flow is low, their mouths are closed. And you're saying even with their mouth closed, with the high resistance and low flow, they're overbreathing? Doesn't make any sense to me at all, right? So I strapped it on 14 patients this week. I got it Tuesday and I measured 14. 7 are hypocapnic. So the normal level is 35 to 45. 2 of the young women in their 20s and 30s were like in the low 20s. I thought it wasn't even real. I grabbed the cannula, wiped it off, stuck it in my nose, and it was normal. It was 40. And so it's fascinating. It's holistic. You have to work on your glucose levels. You have to work on your weight. You have to work on the anatomy. You have to work on your allergies. You have to work on restoring the normal breathing, the dysfunctional breathing you have, and not overbreathe. There's just so much to it. And I just feel like I'm slowly introduced. And then the concept of restoring the brain, no one's talked about, the whole TMS and the hyperbaric oxygen, and there's brain transcranial focused ultrasound coming out maybe in a year. There's all sorts of things. And people aren't there yet. They're still on, I feel like I'm 20 years ahead of everyone. You're on the anatomy. How can I widen? Which method of widening should I do? And there's stuff beyond that.
totally, yeah. So,
Okay, so let's go on now.
one thing, I got one little small question, and then let's do TMS. The small question is, you mentioned on a personal account that even gaining 5 pounds of weight for you seems to move the needle. Is this something you see a lot with patients, or what comments do you have centered around that concept of even a little bit of weight gain or being a little bit overweight? Can that exacerbate sleep disordered breathing disproportionately, so to say?
Yeah, because your airway is just flesh and muscle, and it can be infiltrated with fat, and it makes it more collapsible. So even the slightest amount of weight gain could be impactful. I mean, I know the data says that if you lose 20%, you could drop sleep apnea severity by 60%, something like that. There was an article that just came out recently, and it was pretty well done. But everything you do, like, the nasal sprays help, wearing nasal dilators helps, taping your mouth for some patients helps, a little bit of weight loss helps. And so I know it's, CPAP is your bread and butter, but even technically, if you think about it, CPAP is not normal. I mean, it's not normal to wear something on your face and have it breathe for you at night. And so I tell patients, if you want to get off of it, it may never be as good as CPAP, for those it works for, but you really have to have a holistically go after everything, your sugar levels, because if your sugar levels are high, you're inflamed. You gotta, your weight, what you eat, the foods you eat have to be natural. If you eat processed foods, they're acidic, they may make you overbreathe, things like that, right? So everything you do has to be geared towards, I'm going to breathe well tonight.
So you mentioned something there, made me prompted a thought. Here, this is something no one in the community seems to know the answer to. Maybe you do. Does CPAP simply disturb some patients? That is, we're not saying does it not effectively treat and open the airway, but are there patients where just wearing the CPAP causes more harm than good because their brain is freaking out about it, or it feels wrong, or they're expiring against pressurized air? Is there any data around that that says some people get worse sleep simply by having the CPAP on?
Well, I've never seen any data to that effect. Okay, I've never seen any data, and I look at articles all the time. I've never seen any data saying that CPAP worsens people's sleep per se, right? But they're all looking at it in terms of apnea. But I can tell you 100%, I have seen patients consistently that say they are worse with CPAP. 100%. And that is, I mean, I don't think, pressure, like I know it's controversial, but there's some trains of thought that if you do too much pressure, it can actually damage the lungs. And it makes sense, right? Like a certain amount of pressure is good, too much, and the epithelial linings and whatnot can be stressed out. If you increase the interthoracic pressure too high, you can actually reduce cardiac output, and that's not something you want to do either. And so, and then, and we know when we do sleep studies that everything changes night to night, moment to moment. So the perfect pressure is non-existent. And some patients, depending on their respiratory muscles, if they're weak, it's very difficult to breathe against the air. It depends how much resistance they already have. There's so many factors, how moist the airway is, what your loop gain is. I know you had a whole episode on loop gain, and some people are more susceptible than others to loop gain, and high loop gain. But yeah, so I do think it's not ideal. All I tell patients is CPAP for me is a diagnostic test. I want you to get through 3 months. And then at the end of the 3 months, I want to repeat the brain map to see if stopping the concussion improved the brain. But at the end of 3 months, should you want to stay on it, great. I have no problems with it, or BiPAP or something else. But if you want to come off of it, that's when we go towards the journey of 1 or 2 years to try to get you off that machine, if they're willing to lose the weight, and change their diet and monitor their glucose and positional therapy and allergy treatments and whatever, everything, exercise.
So you mentioned the brain map thing. I've been really wanting to open up this discussion. First of all, what is it? It's TMS, right? What does that stand for? Transcranial magnetic.
Transmagnetic stimulation.
Okay, what is it? Start from absolute zero. I don't think anyone, maybe 1% of my viewers have even heard about this. So what is
Well,
this thing, and what value does it add?
well, let me just share it's disabled. I'd share my screen when you get a chance. But there's a hidden order to everything. And let me know when you get it. I want to just show my website again, really quickly. And I'm going to pull it up on my website here. Because I think
Oh, who can share? All participants. Who can share? Okay, now it should work.
okay, yeah, great. So, there's a hidden order to everything. And this is stuff that you're, oh my gosh, here. This is stuff that you can see my screen, right?
Yeah.
So we do the brain map, we draw an EEG, right? And there's a hidden order to everything. For instance, the face. You're well aware of this, right? There's from the oh, sorry, I don't know why it's not staying there. From the hairline to the eyebrow to the nose to the chin, it should be 1/3, 1/3, 1/3. The lower third should be 1/3, 2/3, further divisible. A line from the forehead should hit the chin. And when you have it, you have good form. and good form also usually means you're attractive. You know what? No. And then also, but form and function go together. You're also happy, calm, focused, you sleep well, you have good mental acuity, you feel grounded, you're at peace. And a lot of people have the long lower third, right? Their lower third is longer. Unfortunately, the middle third is shorter, and that's behind here is where you breathe. And then a lot of people have either, you know, a recessed jaw this way, or the entire maxilla mandible is recessed, right? Anyway, and then there's also the vertical fifths. Oh my gosh, what happened to it? There's also the vertical fifths. Let me just go here. The width, you know, the width of the eye should be the same as the width of the nose, you know, and then the distance between the pupils, that's the interpupillary distance, right? And a line down should hit the corner of the mouth. And once again, a lot of people don't have that. That's why they're getting the transverse, they have transverse maxillary deficiency, right? They smile, you can see the black corridors, their lips are small or near each other, right? Their noses are too narrow. In fact, when I do widen their noses, they think it looks weird, but they got such used to, you know, a normal, you know. Anyway, well, if you have that, you look good and you function well. Well, guess what? The brain has the same order, but you can't see it. You can't see your brain order. So we in our clinic, we say, hey, we're making the invisible visible. Does that make sense? So what does your brain map look like, right? So I wanted to show you what a normal brain map looks like. And so that's a normal brain map right here.
Okay.
And what this is that these are all signals on your head. This is the back of the head. This is the middle of the head. This is the front of the head. Okay. So vision, sensory hub, auditory, motor, executive functioning. And left to right is speed, how fast your brain is firing, right? And actually, I think I may have the talk on here. Anyway, it's okay. And left to right is how fast the brain is firing. Basically, when you close your eyes and you're wide awake and you're calm, eyes closed, wide awake, calm, you're meditating. And when you're meditating, you're an alpha. That's how that Muse headband works. It sees the alpha, the weather is calm. It doesn't see the alpha, the weather is stormy. That's how it guides you, right? So to the left is delta, this is theta, this is alpha, and this is beta. And so basically, this person, when their eyes were closed and they're calm, they were an alpha. It starts in just like your heart is here and it pumps blood everywhere to your foot, to your hand, to your neck. The alpha forms in the back of your head, and then it just shoots out all the way to the front. Does that make sense? Mm-hmm. And what you want is a balance up and down and balance left and right. So for this person, when they close their eyes, their entire brain is like an orchestra firing in alpha, right? And now, go ahead.
For people who are really unfamiliar with EEG and brainwaves, like what is this alpha thing? Like what is it? What's the difference between an alpha and a theta? And why are we looking at the alpha instead of the theta?
Well, what it is that you got 80 billion neurons. They're all firing at different speeds. What alpha is when the neurons are firing slow, like let's say you're on whatever, like they're firing slow for whatever reason, you record those as delta waves. That's the energy that the brain waves are recorded as, that they're exuding, and it's listening in decibels, it's in delta waves. If the neurons that are firing faster, you record as theta waves. The neurons are, firing faster than that, that's alpha, and the fastest neurons are beta, and the super fast ones are gamma. And so I always tell patients you want to be an alpha during the day, and you always hear about the importance of deep sleep, delta sleep at night. That's that slow wave sleep. So I tell patients you want alpha during the day and delta at night. And you see that perfect balance I showed you? You can disrupt that balance with sleep apnea, but everything modulates the brain. You can modulate the brain in a positive way to restore that balance, but you can also modulate the brain to ruin that balance. Smoking pot, drinking, having a chaotic lifestyle, sleep apnea, low hormones, playing soccer, football, something kind of like contact sport, right? Whatever. There's so many different things that can degrade that brain. And so we look for ways to restore it. And so I think that's why you'll have a lot of your patients who are fully compliant on CPAP, great numbers, and they're still symptomatic. You've got people who've gone through all the surgical treatments and they're still symptomatic. The reality is that, did the brain fully restore or not? And you never know. Like even Gimeno, towards the end of his career, he started to focus on the brain. It's pretty fascinating, right? So I think in the end, everyone, Coppelson, Zaghi, all the people you've had, whatever that you talk to on your show, whatever, they're all focused on here. Lee, Gunson, everyone, right? And Relly, Wallin, all of them, right? I think everyone is targeting this, but not realizing it, and they're focused on this. And the TMS just is one mechanism to help restore the brain.
So what is the TMS? What is it? Well,
it's basically like like you can't. It's just basically a electrical coil creating a magnetic field. A magnetic field can cross through your skull and hair and tissues much easier than electricity. That would hurt like hell to put an electric current right on your head, right? So magnetic can cross right through, but then when it hits the neurons, it converts back to electricity and makes them fire. And so what you're doing is
okay.
you're making the brain fire. And so there's different, there's protocols for depression, there's protocols for OCD. That's all that is FDA approved for, is OCD, smoking cessation, and depression. But there's off-label protocols. But one of them could be to restore the alpha. You stimulate at alpha, and then you do different parts of the head and in different ways, and you try to reteach the brain, hey, you know what? We're gonna take you back to where you should have been.
So am I understanding then correctly that you apply, for example, TMS on a patient? They go get a treatment like CPAP or a double jaw surgery, and then you apply TMS again, and you can see an objective difference between those two states? Am I
Well,
understanding correctly?
close.
What?
We do the brain map before and after every major intervention. We have the engineers that come here. I want to do my expansion first. I want to do my CPAP first. I want to do my jaw surgery first. So they want to do it after each one. Does that make sense? So after each intervention, we usually do another brain map. So after, like, we would have done a pre on you and a post after your expansion to see, and a rhino and everything else, right? We just get our repeat testing. But I can tell you, I've done this so much that no matter what benefit you get from an MMA, no matter what benefit you get from an expansion or CPAP, you can get. I mean, if I had to give a number, I usually probably say you'll get 30–40% from CPAP, maybe 30–40% from surgery in terms of this, how you feel. And I always tell them, you're going to get 30–40% just from TMS. So you could do nothing. You could literally do nothing and just walk around open mouthed and, like narrow and like sucking air, right? And do that TMS and still get benefit. It's not ideal. I don't recommend it. So I always tell my patients, I like to stop what's degrading the brain, what's damaging it, not just the breathing, but also, hey, the pot, this and that, and then restore the brain. But you have to remember, once the brain is like off kilter, like once your car is veering to the left, you veer to the right. Does that make sense? And so once the brain is imbalanced, that's why people start smoking pot, drinking, yelling at their kids, taking sleeping pills, whatever, right? And so you can't just sometimes say, stop all that. You have to start actively restoring. And then what they'll say is, hey, you know what? I don't want that drink. I think one drink's enough. Hey, I don't think I need that sleeping pill tonight. I'm feeling better. And slowly they can improve.
So what I'm understanding though is that you actually, like, people come into your office and you literally put this thing on their head and they sit there and there's literally benefits from them having this stimulation, and then they leave and it stays around, right?
Well, it takes years, decades to degrade the brain. So it takes a couple months to start bringing it back. I mean, it's incremental. You notice it after a month, right? But it's daily for about 2, sometimes 3 months. I mean, it's even hyperbaric oxygen. You got to do it for sometimes 40, 50, 60 sessions to start, like healing the bodies, the skin and everything else, glowing black hair again. I mean, it takes a while, right, to restore.
So what else can people do then? Like, I mean, this fascinates me. And right after this call, I'd like to literally restore my brain. So
Yeah, I mean,
what can I do?
I can tell you that I work at one of the offices in a wellness center, and I mapped every trainer there. There are all these masterclass trainers, and I think 90% of them had almost perfect brain maps. So I don't know. I'm just guessing, and all they do is work out all day. So I'm guessing that I think exercise is excellent. So but it's just not something people like to do for some people. But like I would do 30 minutes aerobic, 30 minutes weights, and that would help. Meditation is nice, but who has time for it? It's just hours that you could be doing it, right? And I think you want to avoid, what I find is that our society, just like we're prone to allergies, we're prone to slowing our brains down. And what do I mean by that? Have you ever seen those studies where a kid is kind of like looking at their phone versus taking a walk for 10 minutes? And their brain is much more stimulated when they're out there taking a walk. So the point I'm making is when I do all these brain maps, the biggest thing I see 99.9% of the times is we're slowing our brains down. Like the alpha speeds up until age 20 and slowly slows down anyway, but I'm just seeing tons of slowing in general. For just like everyone's got allergies, everyone's got brain slowing. So you want to avoid things like SSRIs, like Prozac, Zoloft, Celexa. Why? Because serotonin is an inhibitory neurotransmitter. It just slows your brain down more. GABA. A lot of people are on gabapentin for something or another, right? Pot slows your brain down more. Like Ativan, clonazepam, whatever, slows your brain down more. Sitting in your home, staring at a computer, whatever, that's just slowing your brain down more. And so I guess what I'm saying, how many hours do people stare at their phone? It's just slowing their brain down. So it's like an epidemic of brain slowing. So when I see me, I do everything I can to speed it up. And they're like, wow, here's the quote from one. Like, I put people on various medicines that speed them up, not the typical ones. Like these are this is the one CEO who wrote to me, dude, this shit is amazing, almost too good to be true, but feeling really great today.
That's from TMS.
No, that's from another. We did something else, for this person, right? But anyway, the point is, when we speed the person's brain up, it's like you've never experienced it before, right?
Like, have you seen that movie Limitless where he takes the pill?
No. But what
It's a
happens?
pretty good movie. It's Bradley Cooper, spoiler alert, but he basically takes his pill that allows you to access 100% of your brain. It's kind of reminding me of that.
Oh yeah, and that's what it is. Literally, I feel like it's just waking people up. Hey, they can make decisions now. They can do this, and then it's also very empowering when you show someone their brain. And not everyone's slow, but if it's slow, I don't want to, if someone tells you your glucose is high, you're not going to go run out to the ice cream store. Does that make sense?